ये वाला नहीं है, ये वाला तीसरा वाला. A radio frequency ablation, we only did one, and that was done by cool tip RF or cool tip radio frequency. So I will just start from where I left today morning when I was discussing radio frequency. So there I said that in traditional radio frequency, you need to be very clear with regards to anatomy. That is one. The active tip of the needle has to be placed in direction to that nerve, right? So therefore you have to be very precise regarding the anatomy. Then what happened, and that was second, and the third was that we have to have a control over the temperature, because if we keep on burning or increase the temperature, there is going to be burning which will lead to charring, and that will effectively stop the transmission of heat or electricity leading to heat in the surrounding tissue, and hence our radio frequency probe or the process will be not so effective. So imagine with that concept, what these guys did was they introduced a continuous water column at the active tip, by which the tip never got heated to an extent that the charring would happen. What advantage it made for us was, first was that we got a lesion which was, in a case of a standard RF, like a flame-shaped thing, oval shape, and we had to be very close to the nerve or our target. In this case, and for people lazy like me, where you and you are dodgy with your anatomy, so only if you are close to the nerve, this produces around 15 millimeter size of the lesion. That will make sure that even if you are here or there or not perfectly in direction, you can still achieve that lesion. That is one. Second is the charring, the chance of charring and everything gets grossly reduced. So with that concept, this cool radio frequency technology came into being. So what happened is, this is what I was exactly trying to explain, that you have a flame-shaped lesion and which is not there in front. So active tip has to be in direction with the nerve. Whereas when we talk about this, is there is a round lesion, that is one, bigger lesion, that is number two, and the third thing is that it is even in front of the needle. Therefore, when you could see me perform that medial branch, I could just be at the right angle needle to make sure that I could create that lesion. Whereas if I had to do it in the case of a standard RF, I had to be very sure that I was right in the place where the nerve is coming. Again, this is the temperature. This is 60 and 80. This is our sweet spot. If the tissue goes beyond 45, there is denaturation leading to ablation. So this is our sweet spot. So this is the entire thing where we can get that thing. This is the machine. This is the size that I was talking about. So 18. So entire thing comes out to be 15.
Okay, next one.
This is the particular lesion size. Now, one more thing, it is not, everything is not so positive about it. The few challenges what I have felt is that here it is a thicker needle, right? So it is, because it is a thicker needle, sometimes 60 gauge also, some subset of patients and indications issue that we need to be careful about. That is one. Second, not pertaining to spine, but sometimes if we are doing a radio frequency ablation of a superficial nerve, for example, a genicular nerve RF of a knee, especially the inframedial nerve, it is a very superficial nerve. So there are chances that we might damage there might be skin burning.
So aren't we doing a process which has to be fixed right now? The problem lies at the joint instability. We are not dealing with the joint instability, and we are in fact blocking that pain, which is arising from a defaulted or imbalanced joint. Shouldn't we go for joint fixation earlier rather than we are suppressing that pain? So
now, this was something we probably have.
We are not dealing with the joint instability, and
these are the cervical facets, not very have a medium branch growth. Again, very effective treatment. Now, this is what I am doing it in a what you say AP view. We can do it right in the AP view as well as in the lateral view. So this is what we call it as the articular pillar. We just need to be at the center of the articular pillar. This is what we did today. No, again,
I like we send it
we go
to the physiotherapist
about the facets and everything. So there is something in CoolDip which we can do for a discogenic pain also. We can do a bicuroplasty in which we are getting a bipolar and we are introducing two needles inside the disc, and both these discs are in the posterior annular part, and where we are denervating the disc. So this is done for discogenic pain where it is more of degenerative changes rather than debulking what is required in those spine patients. So a small thing, it's an effective method, gives us a large margin of error, and good evidence is there for long-term relief. But what Sir just talked about, I do believe that what of data that has come out in the recent past is company sponsored, and this is one thing which I always feel. But right now what I feel is that the results are equipotent to the ones of standard RF. Only thing is that you can be slightly more casual when you are doing it. Post-procedural pain, that is one thing which is a thing of bother. Thank you so much. There were a lot of questions when post-procedure, so if you have, please ask. We have a few I can take, I think.